Let's start our next session. Yeah. All right, we are going to start our next session. Please take your seats. Our next speaker is Dr. Brad Bossy. And to introduce him, Dr. Janine Rhodes will be introducing him. So Janine. Oh, and I forgot to mention, there are these QR codes at the end of each row. So if you scan this, you'll get access to the whole program for today.
All right, good morning. I'm Janine Rhodes, the Program Director for our MFM Fellowship. It is my pleasure this morning to introduce Dr. Brad Bossy, our graduating third-year MFM Fellow. Dr. Bossy is from Reno, Nevada. He did his undergraduate and medical school at the University of Nevada. He completed a residency at University of California, Irvine, and his mentors there highly recommended him to us. So we were super fortunate to bring him here to Madison for his fellowship. He has been a fantastic fellow with us, and today will present his fellowship thesis project, which has focused on PFAS exposure in the water and preeclampsia in our obstetric population.
All right, thank you guys, and good morning. Thanks for the opportunity to present our research today. It's exciting. So the title of the talk is Preeclampsia. It's in the water. An analysis of PFAS concentrations in the serum of preeclamptic patients in Madison, Wisconsin. There it goes. So I have no disclosures for this talk. Oh, I went back. Here we go. So in terms of background, preeclampsia is common, affecting 2 to 8% of pregnancies internationally each year and is associated with significant morbidity and mortality. Despite substantial advances, the underlying mechanism remains incompletely understood. One working theory is that there's numerous pathogenic insults that may activate 3 common pathways, including endothelial cell activation, intravascular inflammation, and syncytial trophoblast stress, resulting in the development of preeclampsia. As such, further identification of such pathogenic insults remains important to better understand those that may be at risk for developing preeclampsia and work to develop strategies for prevention. PFAS, or per and polyfluorinated alkaline substances, are one major potential pathogenic insult that has been suggested as having an association with hypertensive disorders of pregnancy and preeclampsia. These molecules are extremely stable and resistant to degradation due to their chemical structure. This gives them widespread industrial and commercial uses, but has also caused issues with environmental contamination and toxic accumulation in humans. At the state, local, and national levels, there have been concerns regarding PFAS contamination in drinking water and in surface waters. The current data remain mixed, however, regarding the association of PFAS exposure and hypertensive disorders of pregnancy. These differences may be due to differences in study design, differences in study population, and exposures to different PFAS types, concentrations, and mixtures, which are known to vary between different studies and across regions. The objective of our study was to evaluate for the presence of PFAS in blood of pregnant patients with preeclampsia compared to that of controls in our local population in Madison, Wisconsin. Our hypothesis is that if there is an association between PFAS and preeclampsia, then the number and quantity of PFAS molecules would be greater in the patients with preeclampsia. In terms of study design, this was a prospective pilot case-controlled study consisting of 40 participants, 20 preeclamptic cases and 20 controls. Patients were recruited from May 2021 to January 2023 at a single institution in Madison, Wisconsin. Informed consent was obtained from all study participants, and this study had IRB approval from Unity Point Health Meritor as well as the University of Wisconsin. Inclusion criteria for the study required individuals to have the diagnosis of preeclampsia, which was defined as new hypertension greater than 20 weeks gestation with blood pressures greater than 140/90 2 times more than 4 hours apart. Participants also had to have newly documented proteinuria defined as a urine protein to creatinine ratio greater than 0.3 or a 24-hour urine protein collection greater than 300 milligrams. Preeclampsia with severe features was also included within this group. Participants also had to be greater than 18 years of age, have a singleton gestation, be greater than 34 weeks gestation, and able to consent in English. Exclusion criteria included a history of chronic hypertension as previously reported within the EMR or documented with blood pressures greater than 140/90 before 20 weeks gestation. Individuals were also excluded if they had eclampsia, coagulopathy, multifetal gestations, active withdrawal from illicit substances, or clinical situations requiring delivery prior to enrollment. Gestational age match controls were also enrolled. They were individuals without the diagnosis of preeclampsia who otherwise satisfied the previous specified inclusion and exclusion criteria. For each study participant, once enrolled, whole blood samples were collected into EDTA tubes. Within 1 hour of collection, specimens were centrifuged and the plasma aliquoted. The plasma specimen was then stored at negative 80 degrees Celsius. These samples were then later sent to the Wisconsin State Laboratory of Hygiene, where liquid chromatography tandem mass spectrometry was performed to measure the plasma concentrations of 38 legacy and replacement PFAS compounds. Maternal and newborn data was obtained from the electronic medical record, and the information was stored in REDCap. Statistical analysis was carried out using STATA, and student t-test and chi-square analysis was performed for continuous and categorical variables, respectively. Odds ratios were calculated and logistic regression was performed to adjust for confounding variables. Now for our results. Both maternal age and pre-pregnancy BMI were found to be statistically different between the groups. While gestational age at enrollment was similar between the groups, gestational age at delivery was statistically different. Race was similar between the groups, with the majority of individuals being white. Parity was similar between the groups as well. Only one individual had a history of preeclampsia within each group, and there were no documented smokers within the study. There were a total of 10 individuals within the preeclamptic arm that did have severe features. Regarding the newborn data, as mentioned before, there was a statistical difference in gestational age at time of delivery between the groups. This likely accounts for the differences noted in NICU admission and duration of hospitalization between cases and preeclamptic controls. Fetal sex, fetal weight, the incidence of small for gestational age infant is defined by less than the 10th percentile calculated by Fenton newborn curves, and APGAR scores were similar between the groups. When looking at the sample data, all samples contained PFAS. 16 of the 38 PFAS tested were detected. PFOS was the predominant PFAS within both groups, and PFOS had twofold higher concentrations in preeclampsia versus controls. Here in the left, we see the concentration of PFOS in the preeclamptic arm versus controls being twofold greater. A sensitivity analysis was then performed comparing PFAS concentrations with preeclampsia with severe features versus controls. This analysis found a statistically significant association between PFOS concentrations and preeclampsia with severe features, but this was not true of the other PFAS detected. Here's a graph showing that as well. For PFOS concentrations, quartiles were calculated to identify those concentrations greater than the 75th percentile for all study participants. Odds ratios were calculated to measure the association between plasma PFOS concentration greater than the 75th percentile and the development of preeclampsia or preeclampsia with severe features. Adjusted odds ratios were calculated controlling for obesity or BMI greater than 30. While these numbers do demonstrate a positive association, caution should be taken when interpreting this data. The large confidence intervals reported here highlight the low level of precision associated with each odds ratio, which is likely due to the rather small sample size in this preliminary data. So in conclusion, all samples contain PFAS, PFOS, PFOA, PFHXS, and PFNA were found in all samples, with PFOS being the highest predominating PFAS. It was twofold higher in the preeclamptic arm versus controls, And the mean concentration was even higher in preeclampsia with severe features. But increased sample size is necessary before conclusions can be drawn regarding this association. Strengths of the study include that it was prospective. There were strict inclusion criteria for the diagnosis of preeclampsia. And to my knowledge, this is the first assessment of PFAS in a pregnant population locally. Limitations include the study's small sample size, its unbinded nature. This was also a racially homogeneous population, and there was a disproportionately large number of patients with severe features in the preeclamptic arm. Should also be noted that as a case controlled study, this is only capable of demonstrating associations, and further work is needed to establish causal relationships between PFAS and hypertensive disorders of pregnancy. That brings us to a shout out for Dr. Kumar's lab, who've been great in collaborating on this project. They conducted this study looking at PFOS exposure in pregnant rats, finding increased angiotensin II activity and decreased endothelial dependent vasodilation in uterine arteries and exposed dams. This was published in 2022, and they continue to work to try to unwrap these causative mechanisms. Future directions include expanding the sample size in these human subjects, potentially geomapping to highlight at-risk populations, engaging in patient education and public outreach, and ongoing laboratory work to better understand the causative mechanism underlying PFOS-induced hypertension in pregnancy. Funding was through the fellowship research program. Huge thank you to Dr. Hoppy and Dr. Rhodes for their mentorship throughout this project, as well as Dr. Kumar's lab, Jay, Shri, and Roland for their help and collaboration. Huge shout out to the residents for helping approach a lot of these patients to get them enrolled, and the patients themselves for being willing to be involved in this study. Some references. Open it up to any questions.
So we have time for questions.
Thank you for such an interesting presentation. I guess there were a couple things that stood out to me. Were you surprised, or do you think it was a power issue that there was not a difference in fetal size?
I mean, that's been found in the rat models for sure, that the offspring of dams that are exposed do have smaller size overall. So I think it's likely just our sample size is relatively small.
And do you have a sense of in terms of exposure, because you talk about geocoding and thinking about that. So do you have a sense of, for your population of patients, were there specific groups of people who are more likely to be exposed?
It's something that we've definitely thought about. We do know that there's a lot of well data that's available throughout Dane County and in the Madison area, and there are certain wells that have highlighted increased amounts of PFAS in the drinking water. We also know that the surface water, which at one of the initial slides was showing kind of the chain of lakes that are around Madison, and the surface water does have exceedingly high levels of PFOS. So people who are consuming things like fish would be at high risk for exposure.
Because it's also an endocrine disruptor, right? And so are you seeing in that same population other endocrine disorders?
We didn't, but again, really small sample size.
Thank you.
Yeah, thank you.
So Brad, I have a question. So, because these are endocrine disruptors, there is also a lot of data on how in the lakes, how these chemicals affect the fish population. And there are some reproductive tract disorders that you see in fish or frog and those type of things. Have those been also reported in our area?
In a human population?
No, even in wildlife
Yeah,
population.
I'm not sure.
Okay.
That's really interesting though.
Because there are some of these molecules can affect, like in amphibians,
Right.
they affect the reproductive tracts
Yeah.
and stuff like that. So
Yeah.
I wonder if there is a correlation.
Yeah, definitely could be. Yeah, thank you.
Dr. Bossi, just to talk about geospacing or geocoding or whatever a little bit, I think it's important to know when you have a small sample size, our discussion about the ability to do that. So if you could speak to that a little bit.
Yeah, it's a pretty challenging topic. We do have like a strategy to potentially get around it though, but geomapping a small number of patients would be difficult to find, those associations likely. But interestingly, when you think about like proximity from an individual's home to a certain well, that's probably not what we're most interested in, but rather which wells are servicing certain addresses. It would be challenging though too, because that's just one potential source for exposure. And there's, many, as we know, that it's so universally used, all these PFAS molecules.
Well, and we actually had a conversation about doing this, and so it also can be, when you have a small sample size, it can be, like HPI concerning, like you're pointing out points on a map, and so it might lead you to like identify people easier than if you have a large sample size, and so we were sort of
Yeah.
asked not to do it rather than to do it, so I just think that's interesting to think about.
I mean, this might be a great project, some of the consortium. right?
Absolutely.
Yeah. Yeah, that's a great idea. And in terms of samples, I mean, we've doubled the sample size. We just don't have the results back yet. Yeah.
Heidi.
Thank you so much. This was a great presentation and really made me think about what's in my water. Do you know whether, I know the Survey of the Health of Wisconsin banks a lot of samples, and I'm wondering whether you could explore sort of geographic correlates within those. I know SHO is really interested in sort of using their banked samples for research questions. They don't have a lot of pregnant people, but I wonder if you could answer some questions that would help integrate with your data well using SHO. I don't know if you've explored that at all.
But that's a great idea.
If you send me an email, I'll connect you with them.
Thank you.
That was a great presentation. For Dr. Painsakar's comments, the Department of Natural Resources in Wisconsin is looking at PFAS and collecting studies on that in wildlife. One of the interesting things is that they were looking at where it stays in water levels. And for things like mercury, there's like a known level that it'll collect at, but with PFAS, there's not shown to be a level, which is kind of crazy. But for PFAS in your study, I saw that there's a higher proportion of severe preeclamptics that you saw in your patient population. I didn't see anything for things like early onset versus late onset preeclampsia. And I was wondering if you think with higher patient population samples, if you'd see any difference that PFAS had in early onset versus late, since they're kind of two different disease processes.
Yeah, that's a great point. I think there have been studies looking at early onset versus late. The study obviously highlighted later gestational age individuals. Those were all that were included after 34 weeks gestation. But certainly, higher concentrations, more severe forms of disease. This population, while it's not as generalizable because of the 50% of individuals that did have severe features with preeclampsia, does give a unique opportunity to sort of highlight that highest risk group with these highest concentrations of the chemicals. And I don't think that's been described before because they want such high population numbers. So those are tough cases to find.
Okay, there's one question. Do you know if certain counties based on political affiliation experience more water contamination?
I don't know that in particular. A lot of what I focused on from the environmental side was more focused in Dane County in particular.
Right.
But this is a problem that affects every county in the state of Wisconsin.
Okay. I think we are out of time.
Okay,
Thank you, Brad.
great, thank you.
Yeah. So to introduce our next speaker, Dr. Rose will introduce the next speaker.
I always know to get out of Autumn's way. It's been keeping me on task for a while now. Pleasure to introduce Dr. Catherine Zhang. She's our senior fellow in gynecologic oncology. Dr. Zhang, excuse me, attended the University of Wisconsin for undergrad and med school. In fact, she had a full ride for all 4 years at the University of Iowa. I said Wisconsin, University of Iowa. She also earned her master's in public health at the University of Iowa and graduated magna cum laude there. She went on to complete her residency at the University of Minnesota, and we were happy to recruit her here for fellowship. She's also going to be joining our faculty in September. We had a great group of applicants this year for faculty, and we were really, really happy that Catherine decided to stay with us. Her research interests include cervical cancer prevention, identification of novel biomarkers for early detection of recurrence, venous thromboembolism prevention, and development of innovative surgical techniques. Dr. Zhang.
Thank you for the kind introduction. Good morning, everybody. So today I will be discussing the liquid biopsy, circulating tumor DNA and its promising role in cervical cancer. Globally, cervical cancer is the fourth leading cause of cancer death in women. In the United States, cervical cancer disproportionately affects women of color. So Hispanic women have the highest rates of developing cervical cancer, and Black women have the highest rates of dying from cervical cancer. Although there is effective screening tests for the early detection of dysplasia and cervical cancer, and with PAP and HPV testing, there's really a need for better surveillance strategies for the early detection of recurrence that can increase cure as well as response rates to salvage therapy. History and physical examination are really the only consistent methods that have been reported to be effective for the detection of recurrence. They often only detect recurrence once it's visible or causing symptoms. And really, there's a paucity of data that routine cytology or imaging improve detection of cervical cancer recurrence. As we know, essentially all cases of cervical cancer are attributed to HPV, with 16 and 18 accounting for 70% of cases in the US. Cervical cancer is unique from other cancer types because HPV infection is a crucial step in tumoral genesis, and HPV DNA material is nearly universal in tumor cells. And so a liquid biopsy test to detect circulating tumor HPV DNA in the serum really could have significant clinical utility. I wanted to review a little bit about cell-free DNA and the history. So cell-free DNA was actually originally discovered back in the 1940s in the blood of healthy individuals, but really was not used to detect tumor-specific mutations until the mid-1990s. NIPT, or non-invasive prenatal testing, really drove much of the development of circulating tumor DNA technology. And as NIPT was more widely adopted, it was noted that some women with genetic abnormalities in their plasma, that didn't correlate to fetal abnormalities. And some of these actually were determined to originate from undiagnosed maternal cancer. So in this diagram, as you can see, when released from tumor cells undergoing necrosis or apoptosis, the cell-free DNA we often refer to as circulating tumor DNA or ctDNA. There is ongoing research looking at the use of ctDNA for cancer screening, identification of novel biomarkers, evaluation of treatment response, determining mechanisms of drug resistance, and as well as determining early detection of recurrence. The difficulty in ctDNA is really its detection. The majority of plasma cell-free DNA is derived from normal cells, and there is actually a very low abundance of ctDNA or DNA containing tumor cells. This is typically around 1% of all cell-free DNA, but can be as low as 0.01% in early stage cancers. And so in liquid biopsies, this extremely low concentration of ctDNA in the blood poses a significant technological challenge. So working with Dr. Lisa Berlet and Manish Patankar's group, I performed a feasibility study investigating the use of circulating tumor HPV DNA as a biomarker for detection of cervical cancer. Our hypothesis was kind of twofold. One was circulating tumor HPV DNA is a clinically useful biomarker for the detection of recurrent cervical cancer, and two, it may facilitate early detection of recurrence than routine exams, imaging studies, and PAP testing. Our research aims The first one was to first develop a PCR assay, so a selection of appropriate PCR primers that would be able to detect high-risk HPV 16 and 18. And then our second aim was the use of this validated PCR assay to determine the clinical utility of circulating tumor HPV DNA in the setting of cervical cancer recurrence. Notably, prior studies have also looked into this, and use of conventional PCR techniques have shown a low detection of serum circulating tumor HPV DNA of only about 12 up to at most 45%. However, digital PCR offers much higher sensitivity. So I wanted to just briefly go over how droplet digital PCR works. So the sample is initially partitioned to about 20,000 droplets, and this is using water emulsion technology as well as use of microfluidics. So it's partitioned into the within these microchannels. The PCR is actually carried out within each of these droplets using a thermocycler, and then the sample is run through a reader where droplets containing target DNA sequences display a higher fluorescence intensity and are read as positive droplets, and those below a certain threshold of fluorescence are read as negative droplets and not containing the targeted sequence. So this kind of displays the separation of these droplets and then the fluorescence, as I was mentioning. So then each droplet is plotted on this 1D plot graph of fluorescence intensity, which is demonstrated in the y-axis, and droplet number on the x-axis right here. All the positive droplets are below the red threshold line, which is here. So these are all positive droplets and are scored as positive and given a value of 1. And all the negative droplets below this red threshold line are given a negative or assigned a value of 0. Then starting concentration of the target DNA is estimated through a Poisson distribution modeling. I'm not going to pretend that I fully understand that statistical analysis. So going back, so again, my first aim was to develop the CT-HPV droplet digital PCR assay. So we designed primers that specifically detected the amplicon within the E7 gene encoded by high-risk HPV 16 and 18. So as you may remember, E6 and E7 are the primary oncoproteins, with E6 targeting the P53 induced apoptosis pathway and E7 targeting the retinoblastoma, inhibiting it and thus allowing cell cycle evasion. So then oncogenes E6 and E7 are usually the most often targeted because of their highly amplified sequences in tumor genomes. And E7 is actually preferred because of its high conservation. And that's why we selected primers targeting E7. We then validated this assay with PBS and control plasma that was spiked with increasing concentrations of 16 and 18 segments. And then a droplet digital PCR assay was run for quantification. Optimal annealing temperature and primer concentration were determined using this assay and as well as concentration titrations. And as you can see here, with our droplet digital PCR, we found a very high and good correlation between the expected HPV copy number and what we actually found with our assay. And the titration analysis graphed here showed exceptional linearity with the R-squared value of 0.98. And this was over 5 orders of magnitude. So next we tested this HPV assay within a patient who had cervical cancer. So widely metastatic cervical cancer. We found that she had over 109,000 copies of HPV 18 E7 gene. Her plasma was negative for HPV 16, and this was confirmed with PAP test HPV genotyping, which found the tumor to be HPV 18 positive and HPV 16 negative. So, next steps, our initial next step was really to determine the clinical utility of our assay. And particularly in cervical cancer recurrence. But most recently, after meeting as a group, we wondered why not study the utility of this cT-HPV DNA in all HPV attributable cancers. So this table displays data that was reported by the CDC in the United States in 2021. It shows the incidence of HPV-driven cancers. Oropharyngeal cancer is actually now the most common HPV-related cancer in the US, followed by cervical, anal, and then vulvovaginal. Most of the data looking at ctDNA in the prognostication, early detection of recurrence is actually an HPV-driven oropharyngeal cancer. In other HPV-driven cancers, such as cervical and anal cancer, the data is really limited to retrospective studies and then a very small number of prospective studies. And in vulvovaginal cancer, there's really no studies to date looking at this. So we're in the process of rolling out a longitudinal observational study to validate and test the clinical utility of circulating tumor DNA in HPV associated cancers, so including cervical, vulvar, HPV-related oropharyngeal and anal cancer. And specifically looking at the detection of this in local advanced disease as well as metastatic disease. Looking at this in patients who are under surveillance, so identifying recurrence, and then also quantifying circulating tumor HPV DNA mid-treatment to better assess the treatment, levels of circulating tumor DNA during treatment. And our plan is to really use head and neck cancer as a kind of a control group, since most of the data is in that currently. So I have lots of things to give. Thank you to Dr. Berlet, who served as my research mentor, Manish Panikar and his lab members who helped me immensely, particularly Arvinder Kapoor. Dustin Rubenstein helped me as far as developing the primers for this assay. And then Dan Stevens helped me to figure out how to use Droplet Digital PCR. I received funding from the department for this research, and then as well as for the Carbon Cancer Center provided funding for me to present this at the International Gynecologic Cancer Society meeting. These are my references. Any questions?
So we have time for questions.
Great job, Catherine. You mentioned the literature is more robust in the head and neck cancers. Are they actually at the point where they're clinically using this the ctDNA?
So currently they have an ongoing prospective study. I believe it's a phase 3 trial that we're actually enrolling. We're one of the sites where they're looking at use of ctDNA to determine treatment response and whether or not it would allow de-escalation for patients. So they're not currently using it clinically, but they're definitely moving in that direction.
What a fantastic project.
Thanks.
That's amazing. You know, I guess when I was looking at just the distribution of the types of HPV cancers, can you, with your assay, determine which one it might be originating from? So if you were to do an assay in someone who has rectal HPV related cancer, it's not, you're not able to really define where.
Yeah, so this assay would not allow you to determine the origin since it's just based on serum. So that brings up an interesting question because especially in the surveillance setting, potentially you could be detecting a secondary primary cancer instead of a recurrence of your initial one. So unfortunately, this assay wouldn't be able to tell you exactly where it came from unless, you know, it was a different HPV strain.
And then I was also thinking about ovarian cancer and breast cancer. So do you see this technique?
Yep. There's quite a bit of robust data in use of ctDNA in breast cancer. And there's a lot of hot, research going into ctDNA and ovarian cancer. And Dr. Hardenbach is actually looking into some of that. So
great. Thank you.
Great job, Catherine. And thank you for getting me to think about something besides ovarian cancer in our lab. I appreciate that. I'm wondering, I always think of cervical cancer as such a global burden, and I wonder how you think this technology could potentially be used in limited resource settings.
Yeah, initially when I was looking into research for this, I was hoping that we could use this as a way to initially detect cervical cancer. I think that would allow much wider global utility. Of course, you have to kind of talk about the costs, especially since cervical cancer predominantly affects countries' lower socioeconomic status. But unfortunately, as I alluded to in my presentation, the amount of ctDNA within the serum is so low that it's hard to detect, especially early stages at this time. But maybe, hopefully there is a path in which there's better technology that's developed that we can eventually use it as actually a way to detect it initially.
Great presentation, Catherine. I have a question that we were discussing back here. Would you expect the ctDNA to be elevated or present in patients with dysplasia, high-grade dysplasia?
So not really. It's hard to detect in patients who have dysplasia. I think again, because the numbers are so low. I think even in early cancer, sometimes you only detect 5 to 10 copies in 1 milliliter sample. So they've looked at this in dysplasia, and most of the time you can't detect it.
Thank you, Catherine.
Thank you.
All right, so we move on to our next speaker, and I will introduce Dr. Soma Banerjee. So Soma is a graduate student, a PhD student in Dr. Alex Stanik's lab. Soma received she's an MD OBGYN by training from India. And then after she arrived here in the US, I had the privilege of having her in my lab doing a master's. And she was so traumatized by that experience that she took a five-year break to recover from that. And then now she's back in Dr. Stanik's lab and working on PCOS. So Soma, are you?
Thank you, Manish, for the wonderful introduction. And thanks to the department for giving me this opportunity to present my research. My talk today is titled High-Dimensional Flow Cytometry Analysis of Immune Subsets in the Circulation and Follicular Microenvironment in Polycystic Ovary Syndrome, or PCOS. So the Rotterdam diagnostic criteria for PCOS is the presence of 2 out of any 3 of the following: clinical hirsutism or biochemical hyperandrogenism, intermittent menstrual cycles, and polycystic ovaries on ultrasound. There are accompanying metabolic dysfunctions like insulin resistance, hyperinsulinemia, obesity, and hyperlipidemia, all of which constitute the metabolic syndrome. A little bit of the background. Why are we studying it? Because PCOS is the most common cause of anovulatory infertility presenting in our clinics. It's associated with low-grade inflammation and serum inflammatory markers. It's associated with metabolic, cardiovascular, and psychological health effects, so which have long-term consequences. We are leveraging patient population undergoing IVF in a specialty clinic that gives us the unique opportunity to investigate both the normal ovarian cellular components as well as the effects of PCOS pathology in the ovary. And individual cellular assessment can suggest valuable targets for larger studies and other mechanistic investigations for the pathology. The major challenges, of course, are because of ethical and legal concerns, tissue access, unless clinically indicated, is a difficulty. And here we have the opportunity, because of clinical indications, that we are able to directly access ovarian follicles and the follicular fluid for cellular assessment. The advantages are we are accessing the follicles in a normally indicated clinical care scenario. The patients are undergoing IVF treatment. So this is a group and population of patients who are highly studied and well characterized. We can sample blood, follicular fluid, and clinical data at the same time. And we are monitoring these patients over a concentrated time period. So we have the opportunity to not just get all this clinical data while treatment, but post-treatment, post-ovulation induction, we can also get records for the efficacy of our treatment and pregnancy rates and data regarding all of those. The disadvantages are IVF treatment affects the physiology of the disease itself. We are normalizing some of the pathological conditions which lead to anovulation. So controlled ovarian stimulation can fix some of the hormonal and possible immune pathologies in the ovarian microenvironment. So despite what we know of the clinical manifestations of PCOS, some of the outstanding questions are, what is the inflammatory signature difference in the systemic circulation versus the ovarian microenvironment? Which immune cells direct inflammation, especially in the ovarian follicles? So a detailed map of follicular immune composition at a high subset resolution is still lacking. And the primary objective of this study was to create a cellular map of the normal and PCOS affected follicular immune composition. The inclusion and exclusion criteria are the PCOS or test group satisfy the Rotterdam diagnostic criteria. Our control group has regular menstrual cycles. They have male or tubal factor infertility or a pre-implantation genetic diagnosis of inherited condition. All of our patients have normal ovarian reserve and are planning to undergo IVF. The exclusion criteria are pregnancy, age less than 18 or over 44, and pathological conditions which we know have an immune pathology or have a low success rate in IVF, like endometriosis, diabetes, other immune pathologies like autoimmune conditions, active malignancy, pelvic inflammation, and recurrent pregnancy loss. So this is our protocol for tissue collection. After recruitment for IVF, we collect pre-treatment first blood sample, which is the peripheral or baseline blood sample, and it is usually a patient in the early follicular phase. We collect the peripheral blood immune cells. At visit 2 or after ovulation in a controlled ovarian stimulation, at the IVF transvaginal ovum retrieval appointment, we collect a peripheral blood sample and we collect follicular fluid from 2 to 3 dominant follicles and isolate the peripheral blood mononuclear cells, or the PBMC, and the follicular cells from these specimens, which are then cryopreserved. The study design and analysis protocol. So the cells are thawed and then they are labeled with their surface and intracellular antibodies for transcription factors. We label for FMO controls and single color controls. We have 3 flow cytometry panels looking at innate lymphoid cells or ILCs, antigen presenting cells or APCs, a T cell panel, and a surface antigen panel. We then perform a 5-laser spectral flow cytometry with the Cytek Aurora. The data is analyzed and visualized by conventional gating with FlowJo. We've done GraphPad analysis to do the statistical analysis. We have also done clustering studies on them, t-SNE, followed by flow-sum clustering, and annotation of the clusters using the same markers that we have used in our flow antibody panels. So the questions that we are asking is, is the immune cell landscape in the ovarian follicles distinct from the systemic circulation? These are results from our conventional FlowJo gating of the individual cell populations. For time constraints, I'm not showing the gating strategy. What we have found is the follicular fluid is depleted in plasmacytoid dendritic cells, classical monocytes, and activated and memory T regulatory cells. These are differences in the PBMC and the follicular fluid compartment. We have not designated them or divided them into control versus PCOS. We are looking at all of our patients and the differences between their follicular cells and the circulating PBMC. The next slide is similarly the difference between T cells. So the follicular fluid shows an increase in Th17 and CD4 exhausted cells, but they are depleted in CD4 naive and central memory T cells. We also see some follicular fluid enrichment trends of innate lymphoid cells, ILC1, ILC3, and LTI-like cells, as well as intermediate monocytes and non-classical monocytes, but none of these reached levels of significance. So for this entire study, we have a total number of 33 patients, 13 controls, and 20 PCOS, and these are paired t-test comparisons between the PBMC and follicular fluid immune cells. So we come to the conclusion that the intrafollicular inflammatory compartment is distinct from circulation, with a difference in distribution of key immune cell subsets between the two compartments. The second question obviously is, does PCOS alter the normative signature in follicular and systemic immunome? The only significant finding that we had was that the follicular fluid in PCOS shows a higher number of classical monocytes, and there is a trend for CTLA-4 T regulatory cells to be higher, but again, it has not reached levels of significance difference. The next, we visualize the immunocellular data by t-SNE and clustering by the flow-sum plugin from FlowJo. And we did the annotation of the different clusters. This is just a representative. So I've just shown the data from one small experiment, and this is the surface antigen panel. I apologize, the slides look really cute. I don't know what went wrong. But what we see is that PBMC versus follicular cells show different unique populations. The PBMC shows plasmacytoid cells, as well as CD103 positive T8 cells, and the follicular compartment has non-classical monocytes. So there are differences in the peripheral circulation and the follicular fluid immune compartment. We are analyzing our data further, and we intend to do more more analysis to determine the other panels as well. The conclusions that we can come are, there are site-specific differences between circulation and follicular fluid. PCOS appears to alter the immune cell composition in follicular fluid, and high-dimensional flow cytometry with dimensionality reduction and machine learning is a powerful tool for identification of different immune cell populations and can reveal important differences and targets in pathologies such as PCOS. Future directions. We intend to use machine learning algorithms to determine unique cell populations, which are differently regulated in normal and PCOS conditions. We also would like to do single cell RNA sequencing with limited surface proteome analysis or site sequencing to determine the alteration in cell signaling pathways and transcriptomic programming of the immune cells, as well as non-immune follicular cells like the granulosa theca cell complex. With that, I would like to thank my PIs, my committee, my lab members, the ERP program, the collection and recruiting team, consenting team from the Generations Fertility Care, our patients, and UW Flow Core, and my funding. Thank you.
So we have time for questions.
Thank you for an interesting, that interesting presentation. I guess a couple things popped out to me when you're kind of talking about your model, and specifically obesity and vitamin D deficiency, which are both can be more prevalent in women or individuals with PCOS. And I'm just curious how you're adjusting for that risk in terms of inflammation in your model.
So we have paired patients which matching BMI, and so we have BMI matched controls and I'm actually analyzing the different clinical data as well as I've done cytokine analysis as well. Vitamin D is something we have not looked at, but BMI definitely, and we see there are trends which show that there are differences in the number of oocytes we've retrieved, the beta HCG positive tests and also term deliveries. So we are looking at the data and we see a positive correlation with BMI as well as with some cytokine panels and angiogenic factors. The cellular data is something I'm looking at right now, but we're expecting that we'll see differences there as well. Vitamin D is not something we've looked at.
Yeah, because I would think those are independent modifiers of risk in terms of inflammatory markers. And I think that's really important in your model. The other thing I was curious about was when you described how you did your statistical analysis. I was curious as to why you did multiple paired Ts as opposed to ANOVAs. Like how?
So since we're looking at this same patient, we were looking at PBMCs and follicular cells in the same patient at the same TVOR appointment, and determining just the difference between the two compartments, we decided to do a paired T.
I guess my question is more about, you have multiple outcomes from the same sample. And so how are you modifying the fact that you have multiple samples, multiple outcomes from the same sample, and how that might actually affect your statistical analysis?
I'm not considered that.
You just may, I don't know whether you've published any of this yet, but
No,
that could definitely come up in a review, a manuscript review, in terms of how you actually do your statistics with these samples. Yeah, thank you.
Thank you.
So I have a question. So, these changes that you're seeing, especially with the exhausted T cells, I think you were seeing in the follicular fluid, there is increased number of exhausted T cells. That's something that we have seen, I think, in our ascites sample immune cells from ovarian cancer patients. So, and the question we always have is that because of factors in the ascites fluid, in your case, the follicular fluid, that is leading to that change where the T cells become more exhausted because of the factors, or is it, do you think it's because of actual trafficking of the exhausted T cells into the follicular fluid?
I think it's more of a local pathology.
So it's the factors.
One other question. Have you started to do the matching, matching for weight? Are you able to look at obese versus non-obese?
Yes, so we have patients at all different weight points. So yes. We can, I mean, I have done some analysis on that as well, but still preliminary.
Okay, thank you
you.
so much. So we go on to our last talk. That's by Kate Westerby. And so I'll just briefly introduce you, Kate. So Kate is currently doing a PhD. And so she's a grad student on campus. Before that, she completed her master's in psychology, applied psychology, and also a bachelor's in psychology. And she has held numerous positions on campus, including in the Poverty Institute, and has been a fellow on a grant that was funded, I think, by the WPP, the Wisconsin Partnership Alliance. So we are happy to have you here and looking forward to your talk. I think you had a partner, but they can't come.
Yes, she
today.
got COVID.
She got
tested
COVID,
positive for
sorry.
COVID 2 days ago.
All right,
So,
sorry.
Yeah.
Go ahead.
Thank you. So thanks again for, I think I'm the social determinants of health presentation for the day. So again, I'm a PhD candidate in educational leadership and policy analysis, and I'm part of the core lab. So that's my connection to you all. Sinitra was my partner for this, and she tested positive for COVID, but she is a community co-researcher in undergrad. So this research has grown out of our experiences being teen parents and trying to navigate challenging experiences and wanting better support and resources for other young parents. So the presentation is titled Using Participatory Action Research to Challenge the History of Young Parenthood. So we aim to have you ponder this question today. Dr. Wanda Pillow, who is at the University of Utah, had this question: what type of education fits with the pregnant mothering body? And I added the word young to it because I think that is particularly important. And we'll provide some evidence that education and pregnancy and mothering are often at odds with each other, especially as it relates to young parents. So just defining young parents, we situate young parents in the broader group of caretakers, and then parents underneath that. And young parents include teen parents, but it also overlaps with single parents, parents with young children, and parents of color, which are all populations in the literature. Young parents are also relatively common. About 25% of each births each year are to women 25 or 24 and younger. It's also an equity issue. So young parents are more likely to have intersectional marginalized identities, more likely to be female, low income, racially and ethnically minoritized, and then first generation students as well. And so I'm defining young parents as age 23 or less, given my data set. And then once a young parent, always a young parent. And so this research is guided by reproductive justice principles that all fertile persons and persons who reproduce and become pregnant have basic human rights to have a child, not have a child, and or to parent their children in safe and healthy environments, regardless of age. And this framework was created in the mid-1990s by Sister Song Reproductive Justice Collective, an Atlanta-based Black-led activist group who challenges the choice framework that is in white-centric the feminist movement. And they talk about pregnancy and childbearing are not really choice events. For many people, they are certainly not events devoid of context of a history of eugenics, slavery, conservatism, religiosity, or interpersonal relationships. Reproductive justice approaches also require us to understand the history of a problem. So if we want to attend to the historical influences and the social creation of the young parent problem, several policies and narratives influence our understanding. And I'll talk quickly about the teen parenting epidemic and then Dobbs versus Jackson narratives that occurred afterwards. So in the 1970s, the Guttmacher Institute created a report that described the rates of teen childbirth as an epidemic, and in partnership with Planned Parenthood wanted support for abortion rights by scapegoating young parents. What was interesting is that the birth rates for teenage parents were actually declining before this report. Still, this narrative, scapegoating young parents, has continued today. After Dobbs versus Jackson, this narrative was prominent on social media. Here's an example of a meme that was describing young parents as unqualified and traumatized girls. And so they were saying that the Supreme Court should consider that in abortion rights. The Personal Responsibility Work Opportunity Reconciliation Act of 1996 has also been influential. It's also commonly referred to as welfare reform, and it includes an immense amount of discriminatory language and uses marriage to garner support for it that stigmatizes single parents. In the middle section here, you can see that they imply that being born out of wedlock is causal to negative child outcomes. And you can also see in the final part of the bill, the valuing of vocational education training rather than a liberal arts education focus. Since the research study we're talking about is focusing on education, we focus on the education related aspects of this bill. This bill importantly includes a 20-hour per week requirement to work in order to receive public assistance. And states are allowed to decide what counts as work. And in Wisconsin is one example of a state that decided education does not count towards that requirement. And so for many young parents, they have to work 20 hours per week to receive benefits. They're trying to often work full-time as full-time students as well, because financial aid values being a full-time student. And then they have to manage childcare and navigating all the other systems as well that they have to navigate. I'll finalize this with stigmatizing research, just touching on some articles that have been published describing young parents as harsh, regretful, or at-risk groups. And these articles further a deficit-based narrative about young parents. So one approach that I'm using in my research is to use participatory action research. And this framework shares power in the research process, including selecting the research topic, data collection analysis, and deciding what action should happen as a result of research findings. The goal is to lead to people having increased control over their lives, and it's action focused. So resulting in a product or policy to change knowledge and improve practices and lives. So this is my research design, starting with quant analysis, analyzing educational outcomes for young parents and preparing data briefs. And then I'll show you an example of how I've used that in working with young parents and having them co-interpret the quantitative data with me. And then we're doing kind of a reciprocal cycle where they come up with their own research ideas and I go back to the data and present it to them. And then they interpret it as well. So that's the cycle I'm in right now. The rest is ongoing. The ethnography is going into the IRB this summer, and still doing some qualitative analysis that will lead to publications and presentations, policy briefs. So the questions that I'm asking are, to what extent do young parents enroll and persist in post-secondary education? And then the next two questions are about young parents' interpretations of that data. So how do they explain national enrollment and persistence inequities for young parents in post-secondary education? And what policy or structural recommendations do young parents have to address inequities? For research question 1, I used the high school longitudinal study of 2009. This is a National Center for Education Statistics data set. It's a public data set that in 2009 surveyed 9th graders. And I used primarily that wave and then the wave of them around college when they're after college. Wave 4. And then these are the data placemats I'm using to engage other young parents. The goal is about 15 young parents. I worked with 3 so far, but these are things that they have written on and taken time to really think about and help interpret these charts. So this is an example of some preliminary results. So you can see that if you were a young parent, they are less likely to have applied or registered for college than people who are not young parents, and this is approximately at age 23. And then looking at ever attending college, they're by age 23, they are 41% less likely to have attended college at that age, which I think is an alarming statistic. And when I asked the young moms I'm working with to interpret this, they said, I feel like the percentages are lower for us because they feel like we're a waste of resources, or just a bunch of people don't believe in us because they think, or they feel like we're not capable, or they think we are going to get distracted when we will, but because there's not enough resources, like when it comes to childcare, or not just childcare, but support for the mother too, because unlike other college students, we have more responsibilities and they're bigger, way bigger responsibilities, deeper responsibilities. And a lot of people don't realize that. Looking at college persistence, you can see that this is measured about 3 years after high school. And young parents are most likely to be unenrolled and have no degree. And then, so that's 55% compared to 22%. And when looking at four-year colleges, which ties back to the Welfare Reform Act, where they're pushing more vocational focused jobs, you can see the difference in young parents being enrolled at a four-year college compared to those who are not young parents. And when asked about this, the young parent said, because I feel like it's not just the money wise, it's like the mental too, because obviously going through college itself is super stressful. Now with a kid on top, it's even more, because having a kid doesn't mean that you're just dealing with the kid, you're dealing with financial issues, you're dealing with baby daddy stuff, their family stuff, not just your own family, but the other partner's family. You're dealing with, you know, what am I going to cook today? Because I have class and I don't have time to cook, or who's going to watch her because the daycare canceled today, so I can't make it to class. Or like I'm going to spend an extra hour after class because I need to do this project or something like that. And you can't because you have a kid. Like finding childcare for your classes itself, it's already hard enough to be finding childcare for extra stuff. Like if you need a tutor who's going to watch my kid while I do my work, you know, it's not just the financial part, but it's also like the mental stuff. You go through so much. Like if my kid gets sick, I'm not sick myself. So what if they don't take that as an excuse for me to not be able to miss out? So just wrapping up kind of what we're doing now. So we have this young parent research collective group where they help co-interpret different types of data, provide recommendations, policy research, and we're presenting tomorrow at the American Educational Research Association online. So it'll be myself and a group of young moms and some researchers who focus on this. And the idea is to have these policy recommendations and briefs really led by young parents. So just to leave us with that initial question, what type of education fits with the young pregnant mothering body? It's clear that education is often at odds with reproductive justice, and more needs to be done to create accessible and financially stable pathways for young parents.
Questions?
There's one in the chat.
So there is one in the chat, Kate. Thanks for this presentation. I have a question about some of the terminology around the RJ framework. I'm wondering why you choose to limit the definition of RJ as applying only to fertile people, and what some of the implications of limiting the framework in this way might have.
It's a great question, Lee. So I'm using a 2018 definition from the Ross and Solinger book, and that's the definition they've used. And so it has changed some since then. But I think limiting to fertile people is a conversation I had with a woman who it does have implications for education, especially too, because a lot of people choose or, you know, are trying to plan their work and education around having children. And so that includes men too, right? And being infertile. So it's something I have to think about, and I'll review some of their recent definitions too. But I think that a lot of people have to think about having children, and reproductive justice is, you know, one approach, and that is a definition that they've used before. So thanks, Lee.
That was a great talk. And I think you just demonstrated and illustrated what we call structured disparities. I mean, this is a structure that's been created that really has an impact not only on one generation, but multiple generations when we think about generational wealth.
Yeah.
And so I applaud you for doing this and for helping to educate the rest of us about how success can occur. So thank you.
Yeah, thank you.
Thank you so much, Kate. Thanks for visiting our department and sharing your work with us. I had one nuts and bolts question and one broader question. The nuts and bolts, I'm curious, are you meeting in terms of this style of participatory research, are you meeting with parents individually, and like how are you finding them? Or are there times when you're meeting with them as a group? So I was just curious about that. And the second is, you've got this group here of people who take care of teen parents or young parents or young expecting parents. And I was wondering if there's any wisdom that you wanted to impart to them, or maybe channeling also your partner who's not here today. So those are my two thoughts. questions for you.
Thank you. So I work with a local program at MMSD is how I've met a lot of, I volunteer there and started volunteering there. Not going in saying like, I'm going to do research, but waiting to see if something occurred from that. And so have created just partnerships with the moms who have graduated. And so the data I've collected already is from essentially 2 different focus groups with 3 of the moms who graduated last year. And so they're moms who I've just developed a relationship with, and I check in on them every once in a while and try to help them with things that they need. And they also, you know, help me with my research. And so that's been really just an amazing experience, right? Young people are fun, they're creative, they have like such great energy, and you lose that as you get older, I feel like, in my experience. And so they're just really great to work with. They have great ideas. They're fun to work with in research. And so, so working with them is great. I think I'm seeing a lot of, when I work with the moms, I tend to work with them on their graduation portfolios. And more often than not, most of them say like, my future goal is to have financial stability. And so they're just dealing with so much, so many different factors. You know, we have a huge rent and housing issue in Madison. Rent is super high, and they leave high school and they're trying to figure out what to do often and trying to manage work and childcare and all these things. It can be really challenging, but financial stability is important. I think there are some guaranteed income research areas that I think would be really interesting to work with young parents on. I think educational FAFSA and different cost of attendance policies could be helpful for young parents too, for thinking about policy initiatives. But working with young parents is great. I think just letting them lead the process is important too. I think, you know, there's a lot of saviorism that can come out when you're working with community groups. And so being cognizant of like, you know, that they still have agency to make their own choices, and you're there to support what you can. Yeah.
I have a question,
Yeah.
Kate. So maybe I missed it in your talk, but when you were showing numbers of like the college completion rates, do you have data on where you compare the socioeconomic status and how that, you know, works out with those numbers? Like,
I have not disaggregated those outcomes yet by that, but I do know that the young parents in the sample, 18% of young parents are low income, but 30% of young parents are at the poverty threshold, I should say, not low income. So that they are more likely to be low income. But one of the questions that the moms asked, one of the research questions was, do young parents have family support? And there were 3 different questions in the research that covered this. And the disparities in that are also large, that young parents are less likely to have financial or parental financial support for room and board, so for housing, than people who are not young parents. And so I did disaggregate that data by that and found that people who do attend college do have more parental support who are young parents. If that makes sense. Yeah.
Thank you so much for doing this work. It's really interesting and important. You talked about policy briefs and publications and presentations. I'm wondering about your community partners' ideas about how else to disseminate your findings, as well as elevating the wisdom that they bring.
Yeah, thank you. That's a great question, and something that we haven't gotten to yet in where we're at in the research process. I really want to ask them this and to help them, to have them like lead this process. We do have some connections with legislators too, where it might be, you know, going to meet them and see them. And I think that could be a cool opportunity, but still TBD, and they'll get a say in that part of it too. Thanks.
Oh, Dr. Fatima.
One more. Thank you so much, Kate, for this. I just really appreciate it. And it makes me quiet because there are so many challenges and it's just and it's wonderful to know that people like you are working on these types of inequity issues. It makes me proud of the department and core and so I just wanted to make that comment. And I also wanted to congratulate all of the presenters this morning because to me, this is a reflection of the depth and breadth of the research that's going on in the department. So yeah, thank you so very much.
So Carrie will give the closing remarks.
Well, I think Ellen wrapped that up nicely. I was just going to say on behalf of our chair and our department, thank you for everyone for participating. I think working with Manish has been great. We hope to just continue to diversify what we're representing in our department. And thanks for all contributing to its success.